Well, it's very exciting to be here this afternoon, and I would like to thank all of you. I'm not sure which date it is anymore, if it's Black Friday or Cyber Monday or Super Tuesday, but I know that you have many options to go out there shopping in other courses, so I thank all of you for coming and spending some time with us this afternoon. Also, I'd be remiss right at the beginning, okay, not to thank our sponsors, because without the sponsors, we wouldn't be able to have a program like that. And although I'm going to show many products from these companies, this presentation and this treatment today is about patient treatment. It's not about any one specific product. And you'll understand as we go through the program more what I'm talking about. So we have Paltop Advanced Dental Solutions. We have Rowe Dental Laboratory from Cleveland, Ohio. I don't know if any of you are familiar with this laboratory. It is probably maybe the most advanced technological laboratory in dentistry in the United States. And as you'll soon see also, if you're going to go down the route of digital dentistry, digital technology, it's very important to work with a company and a group and a laboratory that doesn't just dabble in it, but it's experienced in it, has depth in it, has the ability to go ahead and evolve and change as this entire field goes and changes. And you'll see again what we're talking about. Also, another of our sponsors is LED Dental, and they are distributors of 3Shape software and 3Shape scanner, intraoral scanners, as well as Cone Beam CT from Samsung, and many other imaging products. And again, you'll see integration within technology is very significant. So you need to work with or purchase from distributors that are able to integrate and understand the different technologies. And then several items that you'll also go ahead and see from Aseptico, the CalEject, the implant motor you're going to see that we're going ahead and utilize, as well as an ISQ device. And I'll explain what all these products are later on from Aseptico. Now, I'll explain to you kind of who I am. I wear two hats. I have a private practice in Cedarhurst, Long Island, where I practice prosthodontics and implant dentistry. I'll give a shout out to some of my staff members that are here, Nelly, and we have Moya, part of our team on stage, Dr. Waltuck, my partner, and Fatima. Did I miss anybody? No. And a shout out to my parents. You know, I speak all over the world, and in 30 years of speaking, I think maybe this is the second time they've actually ever heard me speak. So, Greater New York Dental Meeting, thank you for giving me the opportunity so that they can go ahead and hear me. And lastly, but perhaps most importantly, okay, you're very fortunate to have a forum like this, and I think we should give a round of applause both to the Greater New York Dental Meeting and the committee that produces the live treatment theater, and the company that actually put this all together, Freeman. So I'd like to give them a round of applause because this is extremely unusual and unique. So I told you I wear two hats. One is in private practice, and the second is I function and work for the company Paltop Advanced Dental Solutions, which provides technological implant solutions, and you'll see all the things that we're going to be talking about. And I function there developing new products as well as being the medical director of the company. Now, if you like what you see here today, and when I'm finished you say, you know, I think I can do that, okay, but I need more training. So there's a course that both I and Dr. Waltuck will be holding, and you can find out about that from the Paltop at the Paltop booth. It's just one aisle over from here. That's going to be held in February, and it's going to be about fully guided implant dentistry, but in a very simple and practical way. Now, if you've read any journals, right, in the past, 1 or 2 or 3 or 5 years, and if you spent any time walking up and down the aisles, right, in the exhibit hall, right, you're going to see, the words digital and digital workflow and all of those things. So I'm going to show you now real digital workflow. Now, that's BMW, make it a car, When we work every day, we treat patients. We treat living biologic systems, right? Look at the technology they come to bring a car, right, to a car. You know, don't you think we should try, or can we do things like that in order of treating our patients? You know, a lot of you probably heard, you know, digital technology, it's exciting, it's not really there yet. Anybody heard that? Not really there yet. Okay, so in 2 hours from now, about 2 hours from now, you'll tell me if you think we're not really there yet, okay? Well, of course, we'll never ultimately be there, right? It's going to be a constant evolution, but are we far enough along down the path that maybe this is something I need to begin to consider? So we're going to talk about things, and we're going to look at, you know, the digital treatment to go ahead and manage patients like this, right? A non-restorable single central incisor, right? And, you know, can we manage that with digital workflow? Sure. You know what? We have tools. It's not just BMW. Tools exist today, right? Exist today that you can go right outside, right? And you can purchase every single tool you need here to go ahead and do this, from things that are in the clinical environment, as well as most of what happens in the digital environment is at the laboratory, okay, to tools that will then go ahead and utilize in the clinical environment. So the things that we do clinically in the digital workflow, there are things that happen behind the scenes that, okay, it's nice to kind of understand, but we don't need to be involved with them. We don't want to be involved in on a daily basis. And then there are things that we need to be able to utilize in our practice to go ahead and do things. And by the way, when I go ahead and you look at that video of BMW, and there was certainly a significant investment that they made to go ahead and be able to produce a digital workflow for building a car, you know why they do that? Because it's more accurate, right? It's more efficient, it's predictable, and it's cost effective. Right? So that's what I'm going to also try and show you today, that the digital workflow, right, shouldn't be intimidating, but it's ultimately something that should be, right, efficient, predictable, and cost-effective. And how do we do that? So we'll talk about things dealing with a single aesthetic tooth. We'll talk about multiple teeth, using digital workflows to go ahead and produce results. And even complex things we'll talk about also. But what I'm going to show you is going to be fairly straightforward and simple, okay? But the same rules that I'm going to show you can apply whether it's a simple case or whether it's something that's somewhat complex in terms of gaining a predictable aesthetic result. And then when we get to the end, okay, don't get scared by the picture, I'm going to show you how far we've come with things that you can actually do today. But here's where we're going to start, and this is what we're going to go ahead and focus on, and this is what we're going to actually go ahead and do here today. See, this is, you know, like live TV, right? And so what I want to do is I'm going to try not to trip on the stage, number one, right? Okay? And I want to try and show you something that, not that you just look at and say, hey, that was kind of nice, but I can't do it. But you know, my goal really is to say, you know, these are things that I can actually implement in my office today. So this is what we're going to go ahead and do. We're going to implement simple treatment, okay? Simple treatment. We're going to look at one tooth. And if I can apply these rules and principles to one tooth, right, then I understand how it applies to multiple teeth or more complex things. So I'm going to show you a simple digital workflow, okay? Digital workflow. And when we use the words digital workflow just means how we do things. It has nothing really to do with digital. Workflow is how we do things. And with digital technology, right, in order not to be efficient, not waste time, you need to understand what step comes before the other step. So if we look at this particular patient, right, who has a fractured maxillary premolar, right, the patient is actually a dentist, and they've elected, they say, you know, I'd rather not have a root canal and a post-core crown and crown lengthening and then a crown. You know, I think I want to go ahead and take this tooth out. So in the digital workflow, right, we collect data. This is an intraoral scan, okay, and we're going to see that later on. I collect data by using cone beam CT. I do surgical planning through the integration of cone beam CT and intraoral scanning. The tools are very sophisticated, right, so I can come up with very precise treatment plans, right, for treatment procedures. And then I'm ready to go ahead and do my procedure. So, you know, once I've gone through that process, right, I can have the patient come in at 9 o'clock in the morning, extract the tooth, use a guide, place the implant, and insert the provisional restoration, and the patient can walk out the door an hour later. right? We want it to be fast and efficient and predictable, right? But we need to use the appropriate tools in order to be able to go ahead and enact that. So let's talk about digital technology just for a minute. And I'm going to make 4 statements. Number 1, the digital revolution is beginning to mature in dentistry. See, digital technology is not new in dentistry, right? When I was in my prosthodontic training program back in 1990, you could buy CEREC. 1990, okay? 27 years ago, CEREC existed, right? Cone beam CT. It's been in my office since 2004, so technology is not new. Well, you know what's changing? What's changing is this. There's the beginning of the integration of technologies, and by the integration of these separate islands of technology, it's creating useful tools. Otherwise, you're just buying a big, expensive piece of machinery, right, to replace something that you used before, but doing the same thing. That's not what the technology is for. It's for us to create tools, right, so that we can do different procedures that are more efficient, right, and more cost-effective for us. And this will have a significant impact in dentistry, and specifically in implant dentistry. But again, only if we have the right tools, and we use the right components, and we use the right workflows. It's not going to work with all the old things that we used to do before. So how can technology, affect dental implant treatment today? Okay, because everything I'm going to show you today, these are things that I do in my office, and I've done in my office every day. So I'm not showing you things that, okay, they're evolving and you can do it in a year or in 5 years or future technologies. These are products that I use in everyday practice. Okay, so number 1, we have clinical data collection. Can we turn the lights down a little bit, maybe? Yeah, no? Okay. Number 1, these are the components. And what it affects. It affects how we collect our data. It affects how we do our restorative treatment plan. It's going to affect surgical treatment planning. And within surgical treatment planning, that means implant placement and hard and soft tissue evaluation. It's going to affect clinical surgical treatment tools, prosthetic treatment tools, and then custom components and prosthesis design and fabrication. All of these are elements in the digital workflow. A central element in implant dentistry is guided surgery, computer-guided surgery. And yeah, I know that's also been around for a long time. My first patent issued in implant dentistry was in guided surgery. It was issued already in 1996. So guided surgery is nothing new. And by the way, it didn't look that different in 1996 from what it looks today. So has that changed, and has that become easier and better? And why do I want to do guided surgery? Well, 1, I can create very precise pre-treatment surgical and restorative treatment planning. I can perform very accurate and precise clinical procedures, precise surgical and restorative procedures, treatment that can really be restorative driven, okay? Not just words that someone says, but you'll see everything starts with what we want the restorative result to be, and then is focused and fixed on that. It complements the team effort, so it enforces the team effort. So it's not just that you took some models, you sent it to the laboratory did a diagnostic wax-up, they made a surgical guide, they gave the guide to the surgeon that was going to place the implants, and they kind of used it, okay? This enforces the team effort so that in the pre-surgical planning and the pre-prosthetic planning, everything is decided and it flows through and it's actually implemented during the treatment. It can be less invasive. Now, I may show you some procedures that don't look so non-invasive, but again, this is a tool, and in some procedures, it's something can be less invasive, and sometimes it's because of the procedure itself, it's a more invasive procedure. For sure, the procedure time in terms of treating the patient is a fraction of what it ordinarily is, and allows the usage of custom tools and custom components. Now, what are the essential elements, okay? In order to do this, what are the different steps and what are the different stages that we need to go ahead and utilize? So number 1 is the data collection, right? And data collection, right, is going to be digital scanning, right? That's of intraorally. Second data collection is going to be CT scanning. Today we use cone beam CT. Next, prosthetic design software, surgical planning software, CNC machining, 3D printing, computer-guided surgical systems, and then significant, even though it's way, way at the end, is we need to use what I will call a technologically compliant implant system. We need an implant system that's been developed for usage with these systems. Because in order to be able to utilize all this prosthetic treatment planning systems, in order to use the surgical planning software, in order to pre-surgery fabricate custom healing abutments or provisional restorations, there need to be libraries designed by that implant system that are integrated within these other systems. See, there are a lot of moving parts. You know, there's no one place that makes really everything. And so you need a implant system that's developed, you know, not just adapted to, but developed for digital implant dentistry. So this is our patient. You know, I left someone out. You know, again, I have to thank my team here, which is Dr. Waltuck and Moya. But I'd like to also now give a round of applause to our patient. You know, this is Tidra, okay, right? Tidra's a little nervous, right? But she was, if I say kind enough, that's like not even like close to what it is. You know, to come up here and sit here and be that patient is not a simple thing. So Tidra's missing several teeth, but we're going to treat just one. Okay, just one of her teeth. Okay, here's what her teeth look like. The teeth are apparently sound. You see, she's missing tooth number 5 in the maxilla. She's missing multiple mandibular teeth. Okay, but what we're going to do is we're going to treat this tooth. And here's the reason we're going to treat this tooth. Anybody know why? Because it's going to be easy for you to see, right? When we retract Tidra's lips and it's right in the maxilla, almost in the anterior, right? It's easy to go ahead and see. And I don't need to do what I'm going to do now and repeat it 5 times, right? I want the opportunity to talk about a lot of different things. And so we're going to go ahead and pick one simple area to go ahead and treat, and we're going to follow through the whole process, and then we'll go ahead and talk about more involved complex cases and how that system and how those protocols, you know, are used for all of those areas. So there it is, okay? Area, tooth number 5, right? A lot of bone, right? A lot of bone. Someone say, well, why would I even need a guide to go ahead and do that, right? You know, and so hopefully when we finish, you'll have a better understanding in terms of doing that. Okay, so we want to get to surgery, right? The patient comes in, the patient's eager to go ahead and have their implant placed, or maybe not their implant, a tooth made, right? So what do we need to do? Step number 1 is we need to collect the data, right? What's the data? We said it's the CT scan, right, and diagnostic models. So how do we do that, right? CT scan we take with cone beam. Today there are different ways of going in and do it. You know, some people order a truck and comes to their office. But if you're doing any amount of treatment, right, you're going to have a cone beam CT scanner, you know, inside your office. And then there's intraoral surface scanning, right? Intraoral surface scanning to go ahead and collect the model data for the patient. But if you don't have an intraoral scanner and you want to start the process, you can do it without an intraoral scanner. You can take regular conventional models, and the laboratory will go ahead and put the models into a laboratory scanner and scan for you. So let's first talk about cone beam CT scanning. So this is my office, and here's my CT scanner that I have. This is from LED, right? Everything that I'm showing you, or the sponsors that we have, these are things that I actually use in everyday practice, okay? Or I wouldn't talk about them. Okay, so this is the Samsung CT scanner, right? It fits, it kind of looks like a Panorex machine. It'll take conventional pans. My machine doesn't take SEPs because I haven't set it up for it. But we use it for panoramic x-rays, and we use it mostly for cone beam CT. And then you see Moya is kind of getting that set up. Okay, and there we have one of my other assistants, that's actually Tia, not Tidra, in there, just to show you kind of how it operates. The patient's positioned in the machine, just like you're positioning the patient for a Panorex, with some slight modifications, but that's how you do it. There are positioning lights, right, and then the head of the machine rotates around the patient's head. Now, if you look at the head of this machine and you see all those colors, okay? You see the blue, the green, the yellow, the orange, okay? That's the light on the head of the machine. And it tells you at what point in operation the machine is. If the machine's on standby, if there's radiation being emitted from the machine, right? So when that cone is spinning around the patient's head, right, you know if it's safe to walk by in the hallway or not. Okay, because you don't necessarily have to stop and wait for the entire spinning to finish if there's no radiation being, you know, emitted. So this is what it looks like. I'm going to go ahead here and show you. So I want to show you what it looks like when the radiation is emitted, Get that off. Okay, there we go. Okay, so you see the light's green now, okay? The light's green, and now it turned yellow. When it's yellow, radiation's being emitted. Okay, and you'll see the scan time is about 14 seconds. So it's very, very rapid, very low dose radiation, very easy machine and predictable machine to go ahead and use, kind of a workhorse. So that's the whole scan. That's the whole length of time it takes. Okay, and now it's back to blue. It means the machine's on standby. These are the images that are initially produced, right? It produces what's called DICOM data. That's a standard format that all the cone beam CT machines that you see and all the CT, medical grade CT machines, you see produce that form of data called DICOM. Now, after the DICOM data is made, and again, this is from LED, right? Reformatting software reformats it, and this is what we're normally used to looking at. So if you're doing any implant treatment, these are the kinds of pictures you go ahead and see, but it comes from the DICOM data. So if we take a look at the cross-sectional images, those are the images at the bottom, right? We'll see the volume of bone that Tidra has. Tidra has a lot of bone, right? I picked somebody that not only would get up here on the stage, right, but I didn't want to make an overly complex procedure. So that's number one. Now, let's talk about how do we get our models, because there are two essential pieces of data. Again, our models, number one, and number two, right? Number two, the CT data. So the CT data, right, that took 14 seconds to capture the data, and it took maybe 30 seconds to a minute for Moya to go ahead and set Tidra up inside the machine. Next, we have the intraoral surface scanning for taking models. So why do I want to go ahead and use an intraoral scanner, right, to go ahead and take models? Why don't I just go ahead and say to Moya, get out the rubber bowl and let's mix up some alginate, right? How much does that cost me? I don't have to spend all this money on an intraoral scanner, and let's take a model. So here, number one, it's an effortless model making. Number two, I have immediate study models. Okay, I immediately see, right, what's going on inside that patient's mouth. Number three, I have very accurate study models. I have full color study models. So I can, in a very rapid period of time, and we're going to see that in just a minute or two, how quickly the data is captured. Not only that, patients come in, and sometimes, the treatment plan is very simple, and I'll kind of write it right there when I'm doing the initial consultation with the patient. Sometimes, I collect all the data, right? I make all my notes, and the chart can sit there for a week, right? Or 2 weeks. Or, I don't know if this happens in your office, but in my office, right, I do the consultation, and if I can't give the information right away or the treatment plan to the patient, the patient says, should I make an appointment now or call me when you're ready? So I say to them, no. Like, I react to that appointment. So I know that if there's an appointment, I have to get the treatment plan done. But sometimes, the chart could sit there for a week or 2 weeks. Now, I have to remember, right, everything there is to do for that patient for sometimes complex treatment, right? So I can go and I can look at all my notes and make the treatment plan, and then when the patient comes back for the consultation, think, well, maybe I need to look at the patient again. I didn't capture this or see that, because I'm not going to take study models with alginate on every new consultation. But in a minute or 2 minutes, I can capture study models so that when I sit down to write that treatment plan, and it can be a year later, I know exactly what that patient looks like, along with all the data that I've collected. I can immediately share that information with the patient. We talk about, when they long ago used to try and sell the intraoral cameras, right, that you took, pictures of to show somebody a fracture in the tooth or something like that. Well, this is like, the light years ahead generation of that. I can go ahead and identify things and show patients things that I can't show them with two-dimensional images. I can go ahead and send the information immediately to the laboratory, right, and they can give me feedback right away. I can go and I can send this information, right, to a referring doctor or a doctor that I'm going in and working with, and they can see those study models right away. We can have a discussion. No setup or cleanup, So how much time did I just save in the office because my staff didn't have to set up and clean up? I will tell you today, we have probably gotten rid of 95% or more of our conventional impressions. And if I say to Moya or any other staff, okay, let's take a conventional impression, an alginate or improgram or something like that, they start shaking. Because the last thing they want to do is kind of set all that up and clean all that up. So we virtually don't do that anymore. right? No pouring of models. Well, maybe you don't pour the models in your office, but we all know that there's a, in terms of maintaining accuracy of those models, right? There's some segment of time, depending upon the material, that you want to go ahead and pour those models, so I can eliminate that. And then I'll put it in what I'll call the wow factor, and the best way I can explain that is this. Oh, maybe 3, 4 months ago, I had a patient, a young mother, come into my office for a consultation, and she's sitting in the operatory, and she brought her daughter with her. This 10-year-old, very open-minded, free-to-speak, little girl. And all she wanted to do was like get out of there, this little girl, and she's kind of tugging on her mom, saying, let's go, when are we leaving, right? And I say to the little girl, listen, I'm going to show you something. It's going to be the coolest thing you saw today, right? And this little girl is looking at me like, there's nothing in here that's going to impress me, right? I said, no, just wait, right? And we take out the intraoral scanner, and I take the scan, right, because I needed the data. And this little 10-year-old girl is sitting there, and her eyes are kind of like popping out of her head. And now she's talking to her mother and saying, like, Mom, like, you got to see this. This is the coolest thing I've ever seen. So that's like the true test, right, of like the, let's call it the wow, the wow factor, for treatment of your patients. And the scanner that I use, that I have in my office, this is here, and this is what we're going to show you today. It's a Trios 3 from 3Shape. It scans very rapidly. For me, if you ask me, they're the market leader in intraoral scanning. And surely, as things evolve and come around, and they have, I've had it 3 years already that I've used it. Okay, it's first going to be, in this machine. Also from LED. Okay, so let's go ahead. Can we switch the screen? Okay, so, because this is live treatment, right? So I don't want to spend too much time before we actually show you something live. Okay, so Dr. Waltuck alone, okay, he's going to go ahead and take a scan of TEDRA so we can collect the data. Okay, to set up and start the process is very simple. I have a cart system that I roll around. Here we're using a laptop system. They kind of tell me most people prefer the laptop system. But you enter the patient's name, you click on the button that says Study Model, and that's it, and you're ready to go. There's no complex setup that's involved in going ahead and doing that. So okay, go ahead, let's scan. Oh, can we switch it to the screen of the scanner itself? Okay, there we go. Okay, so it's telling us now that we were going to start with the mandible, right? And here's how quickly it operates. It's full color. You can buy these in black and white and color. I personally like the color. There's no difference in the, let's call it, quality of the image, but I think you can see things in the color. And certainly if, wow factor is an important part for your patient, color is certainly the way to go. And today I know with the other scanners, more and more of them are, implementing color in the machine. So you see, to go ahead and to scan an arch, right, is, you can do in, 15, 20, 30 seconds, okay? We're just going to do a quadrant because we don't need the entire arch. Okay, it's going to render that data. If there's, artifact or extra information, we can go ahead and trim it away. If not, now we're going to go and scan the maxilla. All right. Alona's just, filling in some of the missing data. Now, when you capture the data, if you're missing data, you'll see holes. If the hole is small enough, the software will fill in that hole. Generally, if it's an area that's important to me, if it was just for a study model, right, I would rather do it, quicker, right, and I'm not going to worry about every hole. If it's something that I'm now going to use to fabricate something on, and here we're going to fabricate something on from here, right, then I want to make sure I collect as much data as I possibly can. So here we are scanning the maxilla. Okay, so we're not in the age anymore of, click, 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 okay? It'll tell you here how many pictures did we capture. It was 348 pictures, and now it's going to stitch all those pictures together, and it gives us our image. And now we can go ahead and we can take a bite registration. Now, teacher's missing some teeth, and it needs a certain amount of space to go ahead and articulate that. So the computer may go ahead and do it, or we may manually manipulate it by going ahead and identifying points and allow them to integrate. Okay, so there we go. The computer decided it was happy, and it went ahead and gave us our byte registration. Now, we're not doing this here, but if you were going to use an intraoral scanner to go ahead and, for a crown and bridge type of impression, you prepared a tooth, that's what you would do. And then you could press that button, and it'll go right to your laboratory, okay, right to the laboratory, and the laboratory can look at that data and tell you if you have enough interarch clearance, if there's enough space for the materials, if you need to modify your preparation, or they can begin working on the Provisional. You know what? Take it off the articulation, and let's just kind of rotate the miles around. Let's look at both arches. Okay, now one other thing, anybody here ever have a patient, you put the restoration in, the patient comes back and then they say, Doc, I'm biting my tongue, right? Something's biting your cheek, could be biting your tongue, right? And you have to try and identify, okay, what's that, overjet relationship? So in cases like that, right, if it's somewhat complex or easy to go ahead and see, all I do is take a scan and I can look inside the patient's mouth. I can spin those miles around and I can look at the occlusal relationship from the inside. So there's all kinds of things you can go ahead and do it. I personally would not buy an intraoral scanner, right, just because it's replacing impression material. It's because of all the other things that we could go ahead and do. Okay, thank you, Tidra. Step one, you can breathe a sigh of relief. You did great. Okay, let's go ahead and go back to our slides. Okay, so we collected the data, right? CT, right? Now I do this in every patient. The patient comes over for a consultation. It requires no extra time, right? Okay, very rapidly, CT scan data is collected. Number two, very rapidly, diagnostic casts are produced. Next step, the next thing that happens, remember I talked about this is restoratively driven treatment, and that's where we are, and that's what this is developed for, is we do a virtual wax up, okay? We do a virtual wax up. So the laboratory now, not you, will go ahead now and wax a tooth up, right? Ideally, where we want that tooth to be. So I don't really care where the bone is. I don't necessarily even care where the soft tissue is. I care about where do I want to go ahead and restoratively, aesthetically, functionally, go ahead and place and position that tooth. And again, that's something that's done by the laboratory, okay? The work and things that you're going to see today here were produced by Rowe, okay? Again, technological laboratory, so technologically evolved that it's a full-service laboratory that uses a digital workflow for everything that they go ahead and do. And they're, I would say, at the very, 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 very cutting edge of digital technology in dentistry, maybe not only in the United States, but in the world. Okay, so it could be one tooth, it could be a full arch. It doesn't matter. You need a diagnostic wax up, you go ahead and you send the data, right? And very rapidly you can go ahead and you can get a diagnostic, or what we call a virtual diagnostic wax up, sent. Not a week later or 2 weeks later or anything like that. Next, after that's done, the laboratory is now going to merge the data sets. They're going to take the CAT scan data that you took from the cone beam CT, and they're going to take the intraoral surface data, and they're going to put them together. And from that step, they can now do surgical planning. Because the surgical planning can only be done once we know, right, where the teeth are going to go. So I'm going to give you an example, okay? Not Tidra, different patient. This is a patient that was going to have the 4 mandibular anterior teeth extracted, and 2 implants were going to be placed. Now, I have a lot of questions, okay? When those 4 teeth are extracted, right, you see the crowding of those teeth? How many teeth are going back? Is it 3 teeth, or is it 4 teeth? Okay, because the patient's not going to have orthodontics to expand the arch or do anything like that. So that's question number 1. Question number 2, when the teeth are extracted, can the implants be placed immediately? Now what's going to be important to know relative to that is where are the implants going to go, where are the teeth going to go? If the implant positions and the tooth position is going to be similar to where they are now, then perhaps the implants can be placed at the same time, right, at the same time of the extraction of the teeth. Well, that's not going to happen if there are 3 teeth to replace now those 4 teeth, right? So then you're going to have to extract the teeth, allow the area to heal, and then come back. Otherwise, you're going to be forced into an area of one of the extraction sockets. If, however, there are going to be 4 teeth placed, and the location, the overall position of the roots and where the teeth emanate from the soft tissue is going to be similar to where the positions are now, then you can extract the teeth, right, and immediately place the implant. And that can also help determine whether you can immediately provisionalize the case, or not, or how you're going to go ahead and do that. Does the patient have to wear a transitional removable partial denture? Can you immediately provisionalize the case? All of those things are going to help make the decisions. So what do we do first? We do a diagnostic wax-up, right, a virtual wax-up, and I say, wow, I could shrink the mesial to distal dimension of the teeth down, and it's going to look nice with 4 teeth, right? So I'm already starting to go ahead and answer some of my questions. Based upon that, the implant positions can be selected. For me, I don't like to place them as a bridge in 23 and 26. I like to restore this every other tooth. There's a better chance of going ahead and developing a nice soft tissue architecture with papilla if you do it in an every other tooth style, as opposed to doing it as a bridge where there's a single implant under each lateral incisor tooth. Okay, so back to TEDRA, okay? So here's TEDRA. The intraoral surface scan has been merged with the CT scan, and a basic plan has been made. My involvement to this point has been sending the CT data along with the intraoral surface data, my TRIOS data, to the laboratory and saying, I want to put an implant into area number 5. All this has now happened behind the scenes. Ro is now, has technicians that are expert in planning, creating the plan. And so when they create the plan, the software allows us to do a lot of different things. It integrates, right, the surface scan. It integrates the virtual wax-up with the area of bone, right, so that you can identify in the planning exactly where you want to go ahead and place the implant relative to the position. It's not just putting it in the middle of the space. It's putting it so that you have a proper emergence profile, right, and a restorable position for that implant, right, without violating any anatomic structures. And so you can look at all the different images, and from all the different images, go ahead and identify that you're not going to run into any teeth and properly position your implant. At this point, right, Ro's done all the planning, except, Ro, this isn't Ro's patient, right? This is my patient, and I'm responsible, and I'm liable for this go-ahead patient. So I have to go ahead now and decide if I like what Ro did. So what happens is there's an online meeting that's set up. So there's Jason, right? Jason is who I worked with on this case. What? Hold on a minute. And so, why don't I hear Jason? Ah, okay, this is why.
Okay, Jason.
Okay. So this is my conversation with Jason.
Let's take a look at the case.
Okay.
Okay, let's take a look at tooth number 5
I'm looking at my
first.
computer screen. He's
okay,
in New York.
He's
in Cleveland.
The restoration or the,
okay.
The virtual
He's showing me what he
can
did.
that for me?
And I'm commenting it. Can we turn the volume up?
Yeah, can you magnify that? Yeah, good. Rotate that a little down for me. Okay. Now, can you rotate it so that I'm looking at it from the direction of the cuspid, from the anterior? I just want to see the profile view.
See, so I'm verifying now that I like his diagnostic wax up first.
Hold on, let's just see that. Just turn it a little more. Yeah, okay, good. Okay, now.
See, I'm looking. I want the cervical position
nice.
of the tooth as
now,
it emerges from the soft
cylinder
tissue
put the cylinder
to be in line with the adjacent teeth.
So I can see where the implant's going to come through. All right, now rotate it back for me so I can go ahead and see what that looks like. Okay, that's great. Okay, now go ahead. Let's go and get rid of the teeth. Leave the provisional on. I just want to see the post coming through. Not the. Let's get rid of all of that so I can see what that looks like. Okay, that looks nice. Now let's go ahead and rotate it up. So I'm looking at the occlusal surface and where that's coming through. Yeah, it's a little difficult now only because that other tooth is in the way.
So Jason planned the mandible at the same time.
Can we get rid of that or we can't get rid of that?
He kind of put something in the way.
No, I can't get rid of it without getting both of them.
Okay, so rotate it a little so I can see it from the side a little, maybe. Yeah, just rotate the whole
Side or
thing.
from the sagittal?
Yeah, just turn the whole tooth now. Yeah, so I can see that. I guess I can see where it's coming through. Okay, that looks good. Okay, let's put the teeth back on and let's look at the CT. Okay, I like the position there. I think you did a nice job with the wax up.
So I'm
All
happy
right.
with the virtual
Okay,
wax
very
up. I'm
nice.
happy how the
Now,
restorative
okay,
position of the implant. The question is
let's take a
it in
look
the
at the
bone in the right place?
cross-sectional view. Okay. Okay, what size is the implant, Jason?
It's 375,
Okay, 375 by how many millimeters? What's the length?
13.
Okay, by 13. Okay. Let's see what happens if we go ahead and change that to 4.2. Can you change the diameter to 4.2 for me?
Yes.
See, so Jason has now opened up the library where
4.2 there.
Paltop, the implants that we're
Okay,
going to
so that's a
place,
4.2.
right, are
Okay, so let's just
located.
leave that 4.2 diameter there for me for a minute over
And he's
there.
changed the dimension
Can
because
we
I didn't like the
measure where
dimension
the
that he
top of the
picked.
implant is until the intersection of the tooth and the soft tissue? Okay, how many millimeters? What is, let's say 3 millimeters?
About 3 millimeters.
About 3 millimeters. So that's good because I'd like to have it like 2 to 4 millimeters so I can develop a nice emergence profile. Okay, and now can we just rotate this cross sectional around so we see what it looks like, three-dimensionally all around the implant? Yeah. Okay, there we go. Okay, let's just keep going. Let's stop it there. Okay, looks like I have nice a nice distance or proximity from the roots of the adjacent teeth. I'm actually in nice alignment with those teeth. Let's keep going. You can keep going around. Okay. And I see that I'm engaging, coming in contact with the buccal cortical bone, with the crestal bone and the palatal. Okay, let's go back and now let's look at let's go look at the other CT images.
See, nothing is left to chance. I can look at everything and understand everything that's going to happen during surgery before I actually go ahead and perform any procedure for this patient. And in working with somebody again like Roe, they have I think maybe 6 or so technicians like Jason who understand anatomy and they understand tooth position and bone and anatomic structures. So they'll pretty much position the implant in a reasonable position, and then you can refine it if you elect to say I want to do something that's a little bit different. But you're starting to see how I can go ahead and say, well, I can make custom things to use at the time of surgery, because I can be very, very precise before I do anything. I know exactly where that implant is going to go ahead from a planning perspective, both surgically as well as restoratively. Okay, so let's move on. The next thing now is I've gone ahead and I've done a virtual wax up, or the laboratory has. They've created a surgical plan. I've validated it and said, yes, I like that plan, or make these changes for me. Now they can make the other things that I request for them. So, well, what other types of devices can we make now? Well, surgical guides, obviously, provisional restorations, custom healing abutments, custom abutments, whatever it is that you elect that's appropriate for that particular surgery. So let's take a look. Here's Tidra, right? There's area number 5. By the way, I don't know if any of you noticed, but you can see she has a deficiency in the buccal plate, right? Even with the deficiency on the buccal plate, you see with the soft tissue concavity, she has adequate bone. And the question is, do you want to surgically correct that, and or not at the time of surgery? But again, with the digital intraoral scan, it's obvious for me. So within the treatment plan, I can make that, that decision. So number 1, a surgical guide for a fully guided surgical procedure is going to be made and is designed directly on that model. I have to send nothing else for that patient. So I don't have to take study casts with conventional material. I don't have to send them convention to the laboratory. I don't have to have them do a conventional wax up, send it back, verify it, validate it, take a CT with a barium template or any of those things. At the time of consultation, I get all the additional data, CAT scan as well as intraoral surface scan in about 3, 4, 5 minutes of extra time or additional time. And I don't even do it. My staff goes ahead and does that for me. Okay, so there it is, a surgical guide that's been designed on the same data set. Next, I want to go ahead and make my custom components. And we're going to go ahead and make a provisional, right? Design a provisional. So what do we do? What the laboratory will do is they can now take that same implant position, import it into software that does prosthesis design. So there's the implant as if you took an impression after the surgery was done. Also is the diagnostic wax up. They select the component that they want to go ahead and utilize. So we're going to do this as a screw-retained restoration. And the provisional component, that screw-retained titanium cylinder, comes from the libraries, right, that Paltop has embedded into the planning software. So within the planning software systems of 3Shape, the major one used in the United States, which would be 3Shape or Exocad or Dental Wings, are these libraries. And so the complete design, right, for the provisional restoration, including the selection of the exact component, okay, is done at this point. All I've done is seen that patient for an initial consultation of 30 minutes, and all this is being done behind the scenes. When this is being designed, we can look at everything. We can look at not only the implant position that's been imported, because that's where the implant's going to go, the design of the provisional to support the soft tissue, and to a certain extent go ahead, fill out some of that soft tissue concavity, but also design it that if it's going to be an immediate provisional, right, we have occlusal relief from that area. See, I want to do as little as possible when I actually treat the patient, right? I want it to be easier for me. I want it to be easier for the patient, right? That's my most expensive time. Right? So I want the laboratory to use its tools to create efficiencies for me. Also in this is the recognition that even if we're doing a guided surgical procedure, sometimes the implant may not be 100% in the exact precise position. If there's a variation of, a fraction of a millimeter or 1 degree of angulation, I don't want to fight with that provisional. See, for me, the most frustrating point and the biggest waste of time, when you do restorative dentistry of any type, right, is when you get a provisional restoration from the laboratory and you're fighting with it, right, for 5 minutes or 10 minutes or 15 minutes or 20 minutes, depending on how big the case is, to get it to fit. That any happen to anybody? So I don't want to do that, right? I want this to be simple and easy. So built into the libraries by design, okay? Because again, what we've done at Paltop is we've designed this for easy usage by the dentist. Built into the library of the provisional component, because it's understood the provisional component needs some leeway, is a spacer. So if you look at the component inside the provisional, I'm going to go ahead and point it out to you. Right there, right? Okay, see here you see the provisional component. Here you see it occlusal. You'll see this space. There's space. Space is built in, so when the implant is placed in that position, the provisional is just going to slide into place. I'd rather spend an extra 3, 4, 5 minutes putting in some, acrylic or a little more acrylic than spend 10 minutes or 15 minutes trying to get something to fit. Okay, so here's the workflow, right? Implant position's been imported, provisional's been designed, provisional component's been selected, right? And it's all going to work, right? And there's our provisional. So these are the things that I'm going to go ahead and I'm going to get back from the laboratory. Okay, so you need to work with someone that can support you in all these fashions. And again, one of the things that I think is kind of nice about this forum, usually when I get up and speak, I can't say words like row, and I can't say words like Paltop, and people come up after and say like, well, how do I do that? Where do I go? So you understand, I'm talking about proprietary products, but it also gives you now, information where you're saying, I can go back to my office and I know who to go to for these solutions. So Rowe can provide those services for you in a full format of planning and guiding and designing and ultimate final prosthesis fabrication. Okay? Now, once we've done that, we're ready for surgery. Except I have to have an implant, right? So, how do I select my implant? Again, for digital implant dentistry, you need a digitally compliant implant system. So that means it has to have surgical libraries, right? Within the planning software, it has to have, right, libraries that are designed for the specific implant with its specific dimensions. You need to have restorative design libraries. The restorative design is not the shape of a crown. That's within the planning software. The restorative design is the components. So are you using a multi-unit? Are you going and using a temporary cylinder? Is it engaging? Is it not engaging? Are you making a custom abutment? All of this data is in libraries. and when the libraries are embedded into the software, then the laboratory that's doing the designing can select those options and design for those specific components. Again, to create less work for you. You need to have sleeves that are designed for the system. Here you see sleeves, and they're 3 different colors, right? You see they're silver, and they're brown or bronze, and they're blue. Those are the system colors within the Paltop system. What do they mean? They designate a drill length. So within the surgical guide, right, the drill length is already pre-selected to make it simple and easy by color. And they need a system that goes ahead and works in it, and a system that's easy and effective and efficient to use. And we're going to see that today. Now, just as a matter of note, right, surgical guides are generally printed, not milled, okay, not milled, while provisional restorations are going to go ahead and be milled. And the reasons for that have to do with you know, efficiencies in the way that it's done. You know, milling is a subtractive process, so each individual piece, right, needs to be worked on. Right? While when you're doing something large and big, when it's printed, it's layered, and it doesn't matter how long it is, it just matters how tall it is. And so today, these are the formats that all the laboratories will go ahead and utilize. Okay, so now let's talk about, just for a couple of minutes, about our implant system, the implant that we're going to go in place. This is the Paltop implant system from, you know, Paltop Advanced Dental Solutions. This is not a system that was just developed to copy other implants, but developed and designed by identifying, let's call it, the 4 core needs that relate to, you know, let's call it modern implant dentistry and our needs. And what are they? Number 1, aesthetics, right? Right, aesthetics, that's important, at least in my practice. Number 2, immediate placement and loading. Number 3, prevention of bone loss and peri-implantitis. Number 4, it needs to be simple, not overly complex, okay? Because I'm going to show you a lot of things that seem to be complex, but again, it's all behind the scenes. You want to do simple things in your office. Okay, so aesthetics, right? How does it address that? And I'm just going to point out, you know, some, you know, prominent items relative to it. Not every feature. There's a concave design built into all what I will call the transgingival components. Transgingival components are what? They're healing abutments, right? They're maybe I'm slide that shows that. Healing abutments, impression copings, you know, provisional components, peak abutments, definitive abutments. Well, why do we make that concave design and not have a straight wall design? And that's because we want to maximize the volume of soft tissue. And by minimizing that and creating something that's concave as opposed to convex, right, we're going to go ahead and have that. If any of you go ahead and do root coverage procedures, or maybe you send them to the periodontist for root coverage procedure, when they go ahead and cover that recession, right, what do they do? It's the first thing they do. They flatten the root, right? Because when it's prominent, right, or when it's convex, right, you're not going to get the soft tissue to cover it. So soft tissue likes space. It doesn't like more titanium, it likes less titanium. So a concave pattern is built into all of those areas. Now, originally, implants, if we go back to the 1980s, right, had a cylindrical straight wall design. More recently, right, they've come up with a more aggressive tapered design with an aggressive thread. And the Paltop implant has the, you know, the newest design. You'll see it some other companies also. And this is a design that's almost somewhat of a combination of those items, where there are 3 segments to the implant. There's an apical tapered portion, right, that has cutting threads on it, right, and an apical taper so that it can avoid anatomic structures. And there's easy insertion of the implant by that tapered portion. But then there's a cylindrical portion, and that gives you compressive threads and increases the stability of the implant itself. And at the most coronal portion are micro threads to distribute stress. In terms of bone loss and peri-implantitis, there's an ultra-pure surface. It's a proprietary process that Paltop uses, and it has an ultra-pure surface. You know, I didn't list it here, but you go to the EDI journal that lists, you know, Paltop has, you know, if not the pure surface, the top pure surface of the, let's call it the top 2 companies in the world. And most companies have, believe it or not, impurities of other metals that you don't want in materials on the surface of the implant. Again, in terms of trying to prevent bone loss and peri-implantitis, you need a stable connection. There's let's call it a conventional hex connection that's on this with very precise measurements and machining, right? So it's a very secure connection, and there's not micro movement of that abutment, which can cause, right, bacterial leakage or fracture of a screw or a loosening of those of the components. The surgical systems, in the conventional surgical systems, use a step drill format through the entire sequence of drilling. So each drill leads the next drill. And then maybe one of the most important features for me is that within the dimensions of the implant, and they're actually, I'm showing you 4, but they're really 5, 325 millimeter diameter, 375, 425, and there's a 6 that's not on there. The core implants of 375, 42, and 5 have the same connection. So what does that mean? Number one, in terms of, let's call it an inventorying of components, impression copings, abutments, right? There's only one for all of these. But because it has a common connection, I can select the implant dimension and diameter based upon anatomical considerations and not based upon needs of emergence profile. So what does that mean? That means I can extract a maxillary central incisor, right? And let's say I'm going to place an implant and immediately provisionalize that implant, right? I want maximum stability, right? You know, I want maximum contact with the bone. I can put a 5 millimeter diameter implant in there and not be concerned that the emergence profile is going to be way too big, right, for that implant, because the restorative component is smaller. It's the same component I'm going to use for a 3.75 millimeter dimension implant. Now, you know, when I first started working with Paltop, I did some of my own testing, some of my own benchtop testing. And I said, okay, you know, listen, these are the implants I'm used to placing. I place Straumann, I place Nobel, right? I place 3i. And I said, okay, let's see in some kind of benchtop objective test, at least for me, right? Are there things that I can measure myself, right, to determine and see, you know, is this an implant that I want to go ahead and utilize? So I looked at 3 tests, 3 things that I can measure on the benchtop. One is extraction torque. 2 is insertion torque, and the 3rd is what's called an ISQ value, right, which is measurement of mobility of the implant. And so I took a block of bone. It's called saw bones, right? It's simulation bone. I can order it in D1, D2, D3, D4, right? And I went ahead and I took implants from each of those companies, right? Nobel and Straumann, right? 3i and Paltop. I used each of their surgical kits, and I placed the same dimension or approximately the same dimension implant using each of their protocols, and then assess the implant through extraction torque, insertion torque, as well as, you know, Ostel value. And if you go and you look at the numbers, you look at the bars, okay, I'm not sure if you can read it from there, okay, but, you know, the blue is 3i, the yellow is replaced, the green is Straumann, and the red is Paltop. All the implants did well, okay, all did well, but if I look at the extraction torque, right, that means if I try to turn the implant after I put it in, so you'll see that, you know, Paltop has the highest number, but basically equivalent, I'll call it the same as Straumann, and all the implants were somewhat similar. 3i a little less. If I look at the insertion torque, right, you know, the amount of torque, and that's usually a measurement we use to see if we feel comfortable of implant stability in terms of immediate placement or immediate loading, right? So if we look at Paltop, we have a number of 43, which is good. I'd like all my implants to be somewhere between 30 and 50 Newton centimeter, right, in terms of insertion torque. So in dense bone, right, this is D1, D2 bone, I'm at 43, right, with Nobel, you know, replaced being at 48. So again, approximately the same, did well. And in terms of Ostel or ISQ mobility, right, measurement of mobility within the implant at that time, right. So all the implants did fairly similar with Paltop, you know, and Straumann and Nobel having similar numbers. Well, what about poor bone, right? Because a lot of implants do well in bone that's good. So what about bone that's a little bit poorer? So if I look at D3 bone, here I'm looking at D3 bone. If I look at extraction torque, Paltop, 30 newtons, well, that's pretty good in D3 bone, right? If I look at, you know, the ISQ or Ostel measurements, right? So we're looking at 61, 64. Everyone did about the same, right? And if I look at the insertion torque, Paltop is at 30 as opposed to the lower insertion torques. So I felt comfortable saying, okay, I'm going to begin this journey placing Paltop implants because I have good objective data. And now over, you know, 3.5 or so years of placing the implants, I've placed it in all different types of scenarios. And just some of my initial numbers, this doesn't include my probably, you know, last, you know, half year, you know, or more of data, you know, of 300 plus implants, including all patients, whether they're diabetic, bisphosphonate users, smokers, steroid users. I haven't excluded anybody from these numbers, right? Extracting teeth, immediate placement, immediate loading, engrafted sites and sinuses in all different areas, okay? We look at that point, we had 13 failures out of those 300 plus implants for a success rate of approximately 96.5%. If I took out my, let's call it immediate load failures, right? we went to 98%. And if I took out my smokers and long-term steroid users and extraction, 99%. So it certainly falls in line, right, with success of all the different centers. But if you take not just my data now, and I look at a 5-year multi-center study, right, over 1,000 implants reviewed, right, 463 people, about even men and women, 17 to 92 years old. Again, nobody excluded from the study, right? Not selecting the patients that are going to be successful, but including even the medically compromised patient. If we compare the mandible to the maxilla, right, we're at about 97% success. Varying bone densities, D1, D2, D3, D4, right? 93%, 98%, 97%. D4, wow, look at that. In the poorest bone, we did the best. Well, you start thinking about, why is that? And again, there aren't big differences in the numbers, but by Paltop design, it has compressive threads and not cutting threads. Cutting threads, although we do have one implant, and we'll talk about that in just a minute, compressive threads are going to go and push the bone as opposed to cutting the bone, and that's going to provide more stability in poorer bone. If we look at one stage versus two stage, meaning burying the implant or putting a healing abutment on it, right? Again, we're looking at 98% or so success. If we look at placing it into extraction sockets, right? One stage, 95%, two stages, meaning bury the implant, there was 100% success there, okay? Putting it into healed bone with an amount, immediate loading. Again, we're looking at statistics that fall in line with successful implant types. Certainly we're looking at 96, 97, 98% success that I've experienced, as well as other centers in this multi-center. Okay, all different types of things. There are 3 different types of implants. We'll call it the Paltop Advanced Implant, the Advanced Plus Implant, and the Dynamic Implant. Now, they all kind of look the same. I flipped through the pictures quickly, but these are the 3 different implants. They look the same. So here are the differences and why I might select one versus the other. And the Paltop Advanced Implant has a conical apex. So why do I want a conical apex? If I'm placing an implant in close proximity to something vital that I might hurt or tear. So for me, what does that mean? If I'm putting it in proximity to the sinus or schneiderian membrane, or in some type of open or closed sinus graft, that's what I want. I don't want an aggressive implant. I want an implant, right, that's going to have good stability, and I want an implant that has a safe apex. The Paltop Advanced Plus is the same exact implant, except there's one aggressive threading thread at the end. So when you're going to go ahead and place it into bone and you want to go ahead and get that extra stability by gripping the bone at the apex, that's the Advanced Plus. This is probably what 90% or plus of the implants that I place are going to be the Advanced Plus implant. And this is the Paltop Dynamic Implant. And this has the same design but a more aggressive thread. So where do I want to do that? I want to use that usually in something either that might be very, very dense bone, or it's an extraction socket. Because when you extract the tooth, right, mandible or maxilla, you're going to have thick cortical plate that's on the palatal-lingual. And generally the implant is going to be positioned more closer and up against that palatal-lingual plate. We generally, if we follow what's called a conventional protocol, is to keep it 2 millimeters from the buccal plate. I don't want to fill that socket because I need to expect some resorption of buccal bone. And so when I go ahead and place the implant, and I'm abutting into that palatal-lingual bone, what's going to happen? The bone is going to, the implant's going to want to follow the path of least resistance, and it's going to get pushed to the buccal, right? So you're going to go and use your guide, right? And all of a sudden the implant is, tipped, the head of the implant is tipped, more to the buccal. Why is that? Because the implant followed the path of least resistance. So with the dynamic implant in the cutting thread, if you hold the implant to that line, it will cut into that lingual palatal bone. So that's generally where I use that implant. Now, we've selected our implant. How do we go ahead and place that implant? So with Paltop, we have 2 guided surgical systems. One is a pilot guide that just guides, the drill itself. You can go ahead and get teacher dressed, okay? That just guides the initial pilot drill. And for some people, that's all they need, right? It will guide the location, angle, depth of the implant placement, right? And so, here's how it works. The guide, you put the guide in place, and you drill till the drill bottoms out, and then you'll come back and you'll use a conventional system to go ahead, or the conventional drilling system of Paltop to go ahead and place the implants. And so there are the step twist drills with depth stops on them, so you can go ahead and create your osteotomies. And a lot of people say, if you just show me location, angle, and depth, I can widen the osteotomies. I want to have some freedom. for that. And then here are the implants that are placed. One's 375, one's 42. Same exact restorative platform, okay? So that means that when it comes to restore it, right, I don't need lots of different impression copings. My staff isn't going to get confused. I don't have to have all this extra inventory on the shelf, right? It's easy to go ahead and do that. And here our sinus graft was done at the same time with regeneration of some of the alveolar ridge. But we're going to focus today on Paltop's fully guided system. Okay, fully guided system. Because if you truly want to use pre-made custom components, provisionals, right, custom healing abutments, custom abutments, you need to be fully guided because there's still latitude and leeway in the pilot guided system. Now, Paltop's system is a little different. When I worked with engineers at Paltop to design this system, I tried to solve problems that I knew that existed. Because I told you in my history, right, I was already designing fully guided surgical systems back in the late 1990s. I developed a company called Implant Logic Systems that I ultimately sold to BioHorizons, and it was their fully guided surgical systems up until a year or so ago when they switched over to 3-shape system. So even though I developed that system, I knew that there were still some limitations, based upon what we can do. So can we do something different? So what I will introduce to you today here is a new concept in digital guidance. Doesn't exist anyplace else. There are different types of guidance. Some people have sleeves on a handle. They call them spoons, and you take them in and out, and they're different diameters, and it matches to the drills. Some people have drills that have a barrel that the shank of the drill fits exactly to a sleeve, but it requires lots and lots of drills. Some people have smart drills, right? You have to, ever see that? You have to kind of be a fighter pilot, right? You look at a screen, and while you're looking at the screen, you're trying to control the position of the drill. Okay, so I introduced the concept, and it's contra-angle based guidance. I'm not really guiding the drill or the burr. I'm guiding the contra-angle. And because I do that, I can do different things. So a concern that people have had is, well, how do I irrigate the drill? Because the second the drill goes into that sleeve inside the guide, right, that guides that drill, it's blocking off the irrigation from going down the drill. Yeah, we can pump the drill up and down and the water goes down, but do I have a more effective way of doing this? So within this system, because it's contra-angle based, right, I have a guiding sleeve that has a window in it. And so the irrigation can go directly on the drill through the entire procedure, number one. Number two, I don't know if any of you ever used guides before, but the drills are really long, right? If I'm putting in an implant that's 13 millimeters long, and I'm putting it in the first molar area, I'm picking a more extreme example, right? The drill isn't 13 millimeters. What is it? The top of the drill, right, has to go to the top of the guide, and the top of the guide is going to be 7, 8, 9, 10 millimeters above the level of the bone. So take 10 millimeters above the level of the bone, add it to that 13 millimeters, add an extra millimeter for drill length, right? You're at 24 millimeters, plus the head of the handpiece, right? 34, 35 millimeters. Try to get your patient to open their mouth wide enough in the first or second molar area that there's 35 millimeters of space, okay, between the bone and their opposing arch. So it can be somewhat difficult, and it can be somewhat frustrating. You say, I'm all excited, I got a guide, I'm going to put the implant in the exact right spot, and then you can't use the guide, right, because the patient can't open their mouth wide enough. So with this contra-angle based system, right, we can do angled entry into the sleeve. So we can save 10 to 15 millimeters of interarch space. So there are many, many, many more, right, applications of the system. So how does that work? When I have a contra-angle based guidance, right, there's a device, I call it the DGS, digital guidance sleeve, and it fits into the head of the handpiece. Well, if you have an implant drill, you'll say, well, I don't have an implant drill that looks like that. So that drill or that contra-angle is part of the surgical kit. It's specifically designed and utilized for this procedure. So we have this device called the DGS. It slides into the handpiece, and then the drills fit in and out. So you need one, right? And the drills fit in and out, and that piece is going to actually guide the drilling of the procedure. That's what it looks like, right? And that's what the head of the handpiece looks like, and they even see it with a drill in place. Now, there's a series of drills, okay, that are at fixed lengths, that you follow in sequence depending upon the diameter of the implant that you're going to place, right? Depending how wide you want to make the osteotomy, right? That's how many of these drills you use. But they go in and out of the same sleeve. So that DGS, digital guidance sleeve, is inserted into the triangle, and then you change the burrs in and out as you're drilling. So here are the steps, right? So here's what happened, right? I took my CT scan, right, on Tidra. I went ahead and took an intraoral surface scan, sent it off to the laboratory. I get back from the laboratory a box with my stuff, right? And I seat the guide in her mouth, right? And now I'm ready to start my procedure. So what is the first thing that I do? Well, I like to make a flap. The surgical kit is designed that if you want to do flapless surgery, there are trephines with pilot drills incorporated in it that are guided by the sleeves. Okay, that are guided by the sleeves. You see there are two dimensions because there are two sizes of sleeves. I like to make an incision in probably 99% of the cases because it's not about seeing the bone, it's about managing the soft tissue. So I want to have maximum volume of keratinized tissue. I don't want to cut it away. To make the incision and then to suture it afterwards is an extra couple of minutes. I'd rather do that than lose all of that tissue. Also, in most of these cases where you have an edentulous area, you're going to have some resorption of the buccal plate. So even though there's adequate bone, take a look at like Tidra, right? You're going to have some falling into that soft tissue. And so I can augment the soft tissue just by making an incision, right? Because then I can push the soft tissue to the buccal. Now, I put in what's called the short pilot drill. You see, that sleeve, if you look at it, you'll see that the drill sticks out, right? So when this drill enters that sleeve, there's no guidance, right? Yeah, I kind of know where it is because I'm going to put it about the center of that sleeve. I don't have guidance until the DGS itself engages the sleeve. So I have to have a drill short enough that that sleeve is going to go into the DGS into the drill guide sleeve before the drill touches bone. So I first put in the short pilot drill, and it will create a hole 2-3 millimeters into bone. So that's a starting point. Right, so there's my my drill inside the DGS, right? That point on the DGS, right, has to go ahead and enter that sleeve before that tip of the drill touches the bone. Once I've done that, okay, I can come back with my subsequent drills, and they're going to fall into that initial hole, and they get guidance from the sleeve. Now, there's a report that comes with this, and the report's going to give you all kinds of information, because there are different lengths of drills. So number one, what's the report going to tell you? Which implant you picked, right? So here, 4.2 by 10 millimeters. It's telling me what the platform is. It's a standard platform, because I'm going to need that information for some of the tooling. Okay, it's telling me which DGS. There's a wide and a narrow, two sizes. Why? Because I need to have a DGS that's narrow enough to put in close proximity to a tooth, an adjacent tooth, or in a small space, or multiple implants in proximity to each other, right? And then I need a wide sleeve for the wider implants because they're not going to fit through, or the drills are not going to fit through that narrow DGS. It's going to tell me the drill length, because the drill length has nothing to do with the implant length. It has to do with the length that I'm going to drill from the top of the drill guide to the base of the osteotomy. Okay, you'll notice everything is in colors. Why? You know, the implant is colored red because that's the color of the vial on the, Paltop 4.2 millimeter implant. This is bronze or brown. Why? Where it says 20 millimeters, because that's the color of those drills, because we have multiple lines of drills. So I've used the short 2 millimeter drill. I'm going to take it out, and I'm going to put in the next size drill, right, the 2 millimeter long drill, and drill to final depth. And then I keep on increasing the drill diameter till I get to the diameter of osteotomy that I want. Okay, so that goes in. You see it gets seated until the DGS bottoms out. There's no lines that I have to look at. I bottom it out all the time. Okay. Now, if you look at this, you'll see that these drills all have a purple band, because there are 3 lines of drills. 1, 2, 3. One line are 20 millimeters in length. One is 25 millimeters, and the other is 30. If the report is telling me that I should use the line of 20 millimeter length drills, right, they're going to all have a brown or bronze, color on it. If it tells me to use the 25 millimeter drill, they're all purple in length, all color on the shank. And if it's 30, then it's going to be all silver. And that's how it lays out inside the kit. For those of you that like the Versa system, a new, very innovative drill system that does a process called osteoidentification, where it expands bone. It's used for closed sinus lifts, right? Their drill lengths are 25 millimeters, and because of our system and the way that the digital sleeve works, right, you can take that Versa burr and utilize it, you know, if you want to use that for bone expansion, in the Paltop guided system. And so this is a kind of a useful tool. I'll just ask the laboratory, pick the 25 millimeter length drill, and then I know it's going to coordinate with the Versa drills. We finish the osteotomy, right? We countersink if necessary. Most of the time with Paltop, you're not going to go ahead and countersink, right? Only when the bone is very dense. The countersink is also guided by the sleeve. And the reason I say that we don't use it most of the time, because that coronal portion of the implant, of where the microthreads are, give a lot of stability to the implant. And so unless the bone is very dense, I want that additional stability. So, you know, you carefully choose whether you want to use the countersink or not. And then the implant itself can be placed directly through the guide. Now, when the implant is placed through the guide, there's a tool, there's a key, and you'll see that there are numbers on the key. These numbers here have nothing to do with the length of the implant. It has to do with how far is it from the top of the guide to where you want the head of the implant to be. So that number is also on the report. It says use, place it to 11 millimeters, place it to, 13 millimeters. So here, if we look it up, we'll see here, okay, we had our implant length, right? We had the drill length. We had the key length. There were 3 sizes, right? And then it'll also tell you the key offset. What does that mean? It means I want to go ahead and put the implant till I get to the 10 millimeter mark. And that's where the implant will be seated to the exact position as planned by the laboratory for the guide and the provisional restoration or the custom component. Okay, so you deliver to that point. I, in fact, don't like to deliver it by handpiece to that point. I deliver it so it's just shy of that. Maybe the last, half, to 1 millimeter I do by hand, because I like to feel the bone. And when you deliver the implant through the system, even though it's designed that way, you lose some of that. Feel. Okay. We also can coordinate and orient our orientation of our hex if we need to go ahead and position that for placement of the implants. Concave healing abutments are placed if it's going to be a one-stage procedure in line with the aesthetic concepts. And here I'm just showing you the 2 sizes of sleeves, right? And again, the report would tell you which one to go ahead and use, but each one will only fit the sleeve that's that size inside the guide. So you really can't make a mistake, with that. This is what the kit looks like. Okay, everything you need is inside there, right? There's also a bone trephine, so if you're placing the implant and it's subcrestal, that bone can interfere with seating the components. This is a self-limiting system. You screw in that what looks like a healing abutment, and it guides the drill so it doesn't damage the implant and clears away any additional bone. Okay, so now let's get to our patient. Here's going to be our site. You're probably saying, okay, when are we do the procedure already, right? So here's what we did to get there: data collection, right? CT scan, intraoral scan, right? That's what was sent to the laboratory. Okay, the laboratory did its virtual wax up and surgical planning. We confirmed it online with the laboratory. The laboratory went ahead and made the custom devices that we're going to go ahead and utilize. And for us, that's going to be the surgical guide as well as a provisional with a specific component, right, that's been pre-selected to make a screw-retained provisional restoration. And now we're ready for our procedure. So I've only had to see the patient for a half an hour one time before any of this happened until we get to the procedure. Now what happens is I get a box. Here it is. Okay, I get a box, and inside the box, this is what it is. These are the custom components, right? Surgical guide, implant, the provisional component, and the provisional restoration itself. So I don't have to stock lots of inventory. I don't have to do lots of things. It's, it's all made so that it's simple. Okay, I'm just going to show you some other. I had Ro go ahead and make for me several forms of provisional restorations. This is a different form. Well, if you wanted to go ahead and insert for immediate provisionalization a custom peak abutment, right, with a provisional that goes ahead and fits that, you can go ahead and have provisional restoration that's made that way also. Okay, so let's go ahead and we're going to anesthetize our patient and get started, because they're going to throw us out of here like in an hour. Okay, do we have some gloves? You ready, Tidra? Oh, these are small gloves. I won't fit into those. Okay, let's seat Tidra back. Okay, we're going to nest Tidra with this, system that I recently started using called the CaloJet from Receptaco. It's computer-controlled local anesthetic delivery. And yeah, I know there have been systems that have controlled delivery of anesthesia before. You know, I found this system to go ahead and be, for me, effective and make sense. It doesn't just go ahead and inject at a slow rate. What the system does is, where's the pedal? It's pedal controlled. What the system will do is the first 10 seconds of anesthesia delivery, it will be at an extremely, extremely low rate for 10 seconds. And after 10 seconds, it will go ahead and it will start to speed up. How do we turn the light on? Do we know? All right, Elena, how do you know we get the light on that? Yeah. Turn the side for me, Tidra, please. No, hold your head straight. Turn to the side. Turn. Okay, I'm just putting some topical anesthesia for Tidra. Close a little for me, Tidra. Okay. Okay, can we have the camera on the table right up over here, where I am? Okay. Okay, so it gives carefully controlled local anesthesia. There are 3 different settings, depending upon if you want something under very high pressure, like intraligamatory injection, right? Or for a Powell injection. A second setting that's let's say, for most local infiltrations. And a third setting that you would go ahead and utilize for, let's say, an inferior alveolar nerve block. I'll go ahead and use it on the setting number 2, most of the time in terms of doing it. I control it with the pedal. I step on the pedal. For the first 10 seconds when you step on the pedal, it will go ahead and give very controlled delivery of local anesthesia. So tip your head up for me, please, Tidra. Okay? We can look inside Tidra's mouth now. Can we have a photographic retractor? Turn to the side for me, please. No, we'll use it in a minute. That's it, okay. But we don't have any light. Can we just use one of the overheads? Let's just do that. I think you'll see better. Okay, so we're going to go and just insert the injection. We're going to go ahead and the first 10 seconds is going to go ahead and be very slow. Now, if I were to take this out, right, or lift my foot off the pedal, it aspirates. So if you're going ahead and you're giving a block injection, right, you're going to have aspiration by just simply lifting your head off the pedal. Now, can you give me the light, please? Yes. Okay. And I don't think you can hear it there, but there's a tone, and the tone is telling me how fast it's going or not. So we've already gone and been doing it 10 seconds, right? And it's going to go, and it's already sped up and doing faster anesthesia delivery. So, I haven't personally tried it on myself, but I've had a very good reaction from my patients in terms of doing it. And so it's one of these things that kind of just makes sense. Initial 10 seconds of very slow anesthesia delivery, and then it goes and speeds up. Okay. Now we're going to go. Can I please have a cotton swab? Okay, we're going to give Tidra some Powell anesthesia. Tidra, please tip your head up for me. That's good. Open for me and turn your head towards me. Okay, teacher, you're going to feel a stick. And you're going to feel some pressure and burning. Okay. So that's the CaloJet. And for me, again, I haven't been using it a very long time, but it's been very effective. I've actually been fairly more impressed with it than I thought I was going to be. So let's go ahead and let teacher get numb. Can I have the photographic retractor now, please? Okay. And let's have the surgical guide. Okay, open for me, please. Good. Turn your head to the side for me, please, teacher. Thank you. What's that? We have the saliva ejector. You're okay? Okay, so tell them the suction's not working. Okay. Open for me. So here's the surgical guide. Okay, now you see the surgical guides that don't need to go ahead and cover all the teeth, but enough teeth that you're going to have stability. You can see that there's a hole in it. It's not because they made it too thin. It's that when I place the surgical guide into position, okay, it should fit snugly. Turn your head a little to the side for me, teacher. Thank you. Okay. I need to be able to look at the windows, and I need to be able to see the teeth in intimate contact. So when I see the plastic in intimate contact with the teeth, I know that the guide is seated completely. Because if the guide isn't seated based on the plan, then all the planning that was done, right, isn't going to work. So this is a way of confirming by having a window, and the window will usually be more than one place, usually on either side of where the implants are going to be placed. It confirms for me that the guide is in the right place. Okay, so there's our guide in place. Okay, we can go back to the PowerPoint while teachers are getting numb. Okay, so the CaloJet from Aseptico. Okay, now the implant that we're going to place, you'll see we've selected for teacher is 4.2 by 13 millimeters. Here's my report. It's telling me that, right? It's red. Why is it red? Because it's the 4.2 millimeter diameter from Paltop. Okay, the drill length is going to be for the 24 millimeter length drill. It's going to be the purple drill that we're going to go ahead and utilize. The offset when it comes to deliver the implant is going to be 11 millimeters. So that's the line I'm going to go ahead and use. So those are the things that I need to know. What's the implant size, right? What's the length of drilling I'm going to do? And for implant delivery, what's that portion going to be? Now I want to point something out to you. When I look at the CT cross-sectional images and I can measure the density of bone, we'll see that my density is around 250 or so or less. Not very dense bone. So what does that mean to me? It means that, well, you know, I may not immediately provisionalize this patient unless I can get really good stability. But because you're all sitting here, you've all been very nice to come this afternoon, we're going to place the implant, okay? We're going to create the provisional so you can see the workflow. If I don't think I have adequate stability, and we're going to test that, okay? We're going to test that, then we'll have the provisional made, but we're not going to send teacher home with the provisional. But again, you know, live TV, live dentistry, so, you know, we have to go ahead and do things as it is. The implant motor that we're going to use is from Aseptico. I really like it. It's really simple and easy to use. It's not overly complex. It's kind of like a workhorse of an engine, right? Pre-programmed numbers in it, and it'll just, you know, by the press of a button, it'll flip for me from my drilling speeds. I like to use about 800 rotations per minute to my implant insertion speeds that we're going to do about 15 rotations per minute. So workhorse of a motor, not very expensive as implant motors go, very simple and easy to go ahead and utilize. And then we're going to go and we're going to use something called the Penguin, right? What's the Penguin? Well, I talked before about ISQ values, right? Or values of implant mobility or stability within the bone. So what does that mean? The way that this works is an original device called Ostel. Penguin is basically the same thing as Ostel. You screw a pin or a rod into the implant, and there's a magnet on top. This device will then bounce a sound wave off the magnet and will measure the amount of time it comes for that sound wave to come back. So imagine I had a ball in my hand, and I threw it against the wall, right? And the ball's going to bounce back to me. Now imagine I did the same thing, but I put a mattress against the wall, right? Something soft. When I throw the ball against that mattress, even if I throw it hard, right, it's not. It's going to like kind of come back, with a, kind of dull. It's not going to come back fast, right? Because it wasn't something that was strong. Well, that's how this works. It measures how stable the implant is inside the patient's mouth. By doing what? By going ahead and bouncing a sound wave and measuring off the magnet. It gives us a number, and then based upon that number, we make an assessment of stability, and do we want to immediately provisionalize the implant? Or, when it comes time to utilize the implants, 3, 4, 6, 9 months later, we test the implant again and look for the trend. Is the number going up or is the number going down? Do I have a problem with my implant, or is it safe to load the implant, or do I want to wait? Any longer? Do we have our suction working? Yes? Okay. Let's check on Tidra and see how she's doing. What can I find another pair of gloves? Can I have another needle? And another carpal septic. Okay, we're just going to test our anesthesia. How do we turn the light on? Okay, tip your chin up for me, please, Tidra. Open wide for me, please. Turn a little to the side. Okay. Feel any of that, Tidra? Okay. How about here? Okay. I think we got some good anesthesia for Tidra. Let's just test the Powell anesthesia and reinforce it. That'll be okay. Open wide for me, please. Do you feel that at all, Tidra? Okay, good. Here? Okay. We have an occlusal mirror. And can I get a mask? Do we have suction yet? And you have a gown for me? Okay, now you might be saying, why am I putting on a surgical gown? This is not a sterile procedure. The mouth isn't really sterile. As a matter of fact, if you look in the literature, you'll see that there's no difference in successive implants, whether you did the procedure sterilely or not. But for me, there are really two main reasons why, I'll go to this extent. Number one, I'm going to go treat patients afterwards. And I don't want blood or saliva or things, splattered on me, so I'm going to stay clean. Teacher's going to stay clean. And it's also a mindset. That I'm going to go ahead and, if I go ahead and I'm wearing this gown and she's all, kind of dressed somewhat sterilely, right? So I want to keep the procedure as clean as possible. I don't want my staff going into drawers and with bloody gloves and pulling things out. So this all goes to that, let's call it culture. Can I get a pair of gloves, please? Yeah. All right, do we have suction? I think I hear it. Okay, teacher, tip your head up for me, please. Still no suction? Okay, while we're waiting for them to fix the technical difficulties, let's take a look at Tidra. Okay, Tidra, turn your head to the side for me, please. Okay, can we have, I think the overhead camera will kind of work here. Yeah, turn. Tip your head up a little bit. Okay, so everyone can see it's kind of exactly like it looked in our photographs and our digital scans. Okay, we can see that there's a slight concavity on the buccal. It's not going to interfere with the placement of the implant itself. Open wide for me, Tidra. Okay, and we can see she's got a fairly wide ridge. So if you were someone that wanted to go ahead and do flapless surgery, you know, theoretically, you could go ahead and do that here. Here, we're going to open a flap for two reasons. Number one, by making an incision, I can help start to correct that soft tissue defect by pushing the soft tissue out to the buccal. If we put the provisional on or the healing abutment. Number two, you'll have better access to see what's there. So only if I have all the bone that I need, as well as all the soft tissue I need, and I'm not going to lose keratinized tissue, will I go and I utilize a flapless type of technique with a trephine. Okay, where's the surgical guide? We already looked at that. Open for me, please. Okay, but I'm going to put the mirror in so you can get a view. You see, it goes right in. It fits very positively. Shouldn't be falling out. And there you see how that fits. You know what, let's try and use this camera right here so that we can see the windows in the surgical guide. Yeah. A little difficult to see. No, and now you're on the curing light setting. Okay. Okay, how are we doing on the suction? Well, let's take a look at the surgical kit while we're waiting. Okay, so can we go ahead and have the camera that's going to focus on this stage right here? Okay, this is where I want to be. There we go. Okay, so I'm going to rotate this so it's easy to look at. Okay, so there's my kit. Within my kit, I have my con triangle, right? That's set up for the DGS. I have a torque driver. I have my short pilot drill. I have my 3 lines of drills, 20, 25, and 30. With Tidra, she was set up for the 25 millimeter line, okay? Those are the purple drills. So I can basically ignore these other 2 lines. I'm only going to be involved in this line here. Her implant is 4.2 millimeters in diameter, which means I'll go down this line. But remember, she had very low Hounsfield density. We talked about 225, 250. So we may actually under-drill the osteotomy. We may not drill all the way to the drill that's in the red line, which is designated for 4.2. We may go ahead and stop an area number that's designated for 3.75. We'll see how the bone feels when we prepare the osteotomy. Here is the DGS. It's the wide one that we're going to go ahead and use. So we're going to go and set that up to go ahead and place that inside the DGS. So here's my handpiece. We're going to use the photograph retractors. Here's my handpiece. I'm going to open the latch. I'm going to put in the short pilot drill. And I'm going to slide the DGS into place and close the latch. After I use the short pilot drill, remember I have to engage the surgical guide with the DGS before the burr touches bone. Then I'm going to come to my line of my 2 millimeter drill, my drill for 3.25, 3.75, and then decide if I want to go and I want to use the 4.2 millimeter drill or not. Any suction? Still no suction. Elena, we working on the suction? Okay, can we show the motor here? We're moving, yeah, okay. When I look at the motor here, I've got a number of settings, 1, 2, 3, 4, 5. I use setting number 2, which is showing me now it's going to drill at 850 rotations per minute. That's been preset, okay? I can change those settings if I want, but every time it's going to be that speed. And when I want to tap, I'm just going to press number 5, and it's set for 15 rotations per minute. I can also control the flow of irrigation, how much or whether I'm going to have irrigation or not. So right now we're going to put it back to the 850 rotations per minute. What's that? Okay, that's from local anesthesia. Okay. Do we have an ETA on the suction? Anybody got a bucket? Anyone know how to fix suction out there? Okay, so we got a portable suction coming. Here we go. Okay, Moya, we need to change the suction tips. And it'll start. Okay, thank you. Aseptico, you saved the guy today? Let's hear you give a hand for Aseptico. Yeah. There we go. Okay. Music to my ears. Suction. Thank you. Okay, did you lift your head up for me a little bit? Good. Okay, put your head back now. Good. Tip your head up a little for me. Very good. Okay, do we have a photographic retractor again, please? A photographic retractor. Okay, and do we have the surgical guide? Surgical guide's in teacher's mouth. Okay. Okay, we're going to put that down here. Okay, so we're going to go and we're going to make incision. Can we turn the light on, please? Tip your head up for me, please. Turn your head to the side for me, please, teacher. Tip your head up a little for me. Okay. Turn your head to the side a little more, and a little more light. No, a little more light. Okay, that's good. That's good. That's good. No, no, give me light. No, we need to see. Okay. Okay, so now I'm going to make an intracircular incision here, right? And I'm going to make a little larger incision than I ordinarily would. Okay, now we're not using that camera. Okay, so I'm making this intracircular incision. I want to be able to reflect the flap enough for two things. Number one, I want to be able to go ahead and give you access so that you can see, but also I want to be able to go and correct the deficiency that exists from the concavity. And so if the incision is too small, I won't be able to push that tissue out. And so on the crest of the ridge, I'm going to make a crestal incision. I'm going to go a little bit more to the palatal, okay? That's called palatally base because I'm going to push all that tissue to the buccal. Okay, do we have the mirror, photographic mirror? Okay, and in the mirror, there we see our incision. Tip your head up for me, little teacher. Good. Okay, good. Did we lose the suction? Okay, Elena, Aseptico people. We lost our suction. It seems there's no power. You can close there and rest there, teacher. Okay, there we go. Okay, let's come back to, there we go. Okay, I'm just going to go ahead and separate all the fibers here, and then we're going to reflect the soft tissue. Okay, can you hold the photograph retractor, please? Thank you. Okay, let's go and take a look. We reflected the soft tissue. I'll give you a better view. Of the area. Okay, now we're ready to start preparing our osteotomy. I'm taking my surgical guide. I'm putting my surgical guide into position. I'm checking my windows. Let's go ahead and take a look at my windows to make sure everything's seated properly. I'm looking in the area of the windows. Here's one window. You see, it should fit intimately with no space. Second window, right? And posteriorly, again, another window. Okay, another window posteriorly. I want to make sure that it's seated all the way posterior as well anteriorly. Okay. Here we see the DGS. You see the irrigation going through the window, a lot of irrigation. I'm going to go and you see how it fits. It fits into there without, tip your chin down now, please. Down, 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 down. Yeah, okay. Okay, and now we're going to drill the osteotomy. Okay, and so I've drilled till it bottomed out. Now I'm going to go change my drill. That was the short pilot 2mm drill. I am now going to change the drill to the longer drill. Also still 2mm, but I have my initial guidance already all set up. So I've going to my kit. I picked out of my box from the purple line. Okay, we can see the drill has the purple on the shank. And I'm going to put that into my handpiece. Okay, so now when I go and I put the drill in, it will naturally find its position. So it's in its position, and now it's getting guidance. I finish my next osteotomy. I'm now going to go to the next drill. I just took my 2mm drill out. I'm going back to my kit. I'm going to the next size, 3.25 millimeters. The bone doesn't feel bad, by the way. Okay? Do we want to see the osteotomy? Let's go take a look. Dr. Waltuck suggested that. I'm going to show you the osteotomy. Can we use the close-up camera there? And we'll get another retractor inside there. Okay, you can use that retractor. Moya, can you focus that camera for us? On the mirror, yes. We have no light, yeah. You know, I'm going to do something for you so you can see that better. I'm going to put in a guide pin. Suction for me, please. And we can see our implant position. Okay, we're moving to the next drill. This is the 3.25 millimeter drill. I know it's 3.25 because it says 3.25 on the shank of the drill. Okay, I feel that I'm in the center of the hole, and I'm drilling the hole. And there, I finished the next drill. That was 3.25. I'm now going to move on to the 3.75 millimeter drill. All of them have the purple shank on them. Okay, and I've drilled to 3.75. Now I'm going to go to the, 4.2 millimeter drill, and I'm going to drill a little bit inside that because, although the bone felt fairly good, I don't want to go all the way. The cortical bone felt very dense, so I'm going to go and take the countersink. It's the red countersink, and the reason I am using the red countersink is because it's a 4.2 millimeter implant. Okay, and we're ready to place our implant, but let's go take a look at our osteotomy first. Okay, we need to retract. Moya, you can suction for us while we're retracting? Yeah, you go ahead and retract for me. Okay, that might be in the way. You're in, that's good? You can see? I'm in the way. Okay, there's our osteotomy. Everybody happy with that osteotomy? Yeah, looks like it's in the right spot. Okay, let's go place our implant. Okay, Moy, can you get us the implant, please? I'm going to meanwhile set up the drill. I'm going to go and I'm going to find the proper implant key. Remember, the report said to go ahead and to deliver the implant to the 11 millimeter line, so I'm going to deliver it down to about 10 millimeters. Okay, so here's my implant key. Let's open the implant. Okay, let's, Moya, hold the implant to show everybody. Okay. You got to hold it up over more. Yeah, there we go. You see, it says it's the A+. That's the one that I wanted to use. One aggressive thread, 4.2 by 13 millimeters. Okay, let's open the implant and dump it on the counter. I'm going to seat the guide back inside the patient's mouth. Okay, now I'm going to go ahead and insert the implant. The implant is encased in a titanium vial, not in plastic, in titanium. I'm going to go ahead and, insert it. It just pops right inside. It's very stable. See, it's not going to shake or fall out. I am going to remember to change to a tapping speed, right? I don't want to go ahead and put that in too quickly. And here we go. We're going to put it in right through the guide. So it's going right to position. Yeah, the bone actually feels fairly nice so far. What's that? Yes. We're going to go ahead and we're putting it at a torque of 35 newtons. I'm actually going to raise it up to, maybe even 45. And I've turned it almost the whole way there. Okay. I'm going to take this off. Let's go take a look at our implant. I'm going to take the guide off. Okay, Moya, suction for me, please. Alone, please retract for me. And there's our implant position. Can we see it? Yeah. Okay, now I'm going to give it its final turn to position. I have my torque driver. On this torque driver, I can control the amount of torque. You'll see there are these numbers, right? And so by turning the dial, I can go ahead and I can set the torque value. So let's go ahead, and right now I have it set to about 35 newtons. Open wide for us, Tidra. Thank you very much. Okay. Okay, and I'm just going to rotate the key until my flat's to the buckle. It's just kind of good practice. I know the hex is always to the buckle. Okay, so now the implant is set to its final position. Let's take a look again. Suction for us, please. Okay, and there we are. Now we're going to go ahead and can I please get the pin? Okay, we're going to test the ISQ value. So I'm going to go ahead and I'm going to use the penguin device. Here's the penguin device. Let's turn it on. Turn that out. Okay. Here's a pin that I'm going to screw into position. Okay, teacher, turn your head to the side a little for me. Yeah, we can see that pin. Now I'm going to take the penguin. Oh, I just turned it off. It's not what? No. And I have a number of 74. Let's see if we can see that number. Oh, we missed the number. I'm going to try and do it quicker. 74. Not a bad number. As a matter of fact, now I'm going to go ahead and I'm going to test it the other way. Again, 74. Okay, that's actually a good number for immediate provisionalization. If you look at a study conducted UCLA by Peter Moy a number of years ago, he demonstrated that if implants had numbers of 70 plus, it was a high rate of survival for immediate provisionalization. Now I'm going to go ahead and well, even before I remove that pin, I'm going to take my provisional and just slide it into place. I kind of like to look at it, really quickly then. So here's my provisional restoration. Teacher, your implant's in. Okay, here is the provisional restoration, and that came directly from that design. So this was machined from the exact design that we went ahead and just saw. So let's go and position that into place. Okay, and I see if I just slide it over that pin, I'm going to try and get my hands out of the way. Turn your head to the side for me, little Tidra. Okay, there's the provisional restoration. Right, kind of right exactly where it should be. So now we're going to go and we're going to get the real component. Yes, we can move this out of the way. I'm just going to take the screwdriver. Thank you. I need my elevator, please. No, I'll use this. Okay, so here's my component. This is the titanium sleeve, exactly as it was selected again in the design by the laboratory. I'm going to place this in place. Open wide for me, please, Tidra. Okay, I'm going to screw this into position. Do we have a throat pack, please? Moya, do we have a throat pack? Okay. Okay, open wide for me, Tidra. I'm just going to put a throw pack so I don't have to worry about, Tidra having an extra lunch today. Or maybe now it's more of an afternoon stock. I just went in and seated the component with a couple of turns. Now that it feels like it's in the right position. But it feels like there might be some bone that's interfering because the implant is placed as planned slightly below the crest of bone. And so I'm going to use another very nice kit, and this is a Trephine kit. These Trephines are made to clear the bone around the head of the implant, but in order so that I don't damage the implant done efficiently, there are healing abutments that are placed first initially on the implant, and they guide the Trephine and prevent it from actually touching the implant itself. Okay, so here's the healing abutment. I'm going to screw that into position. Open wide for me, please, Tidra. Thank you. I'm going to change the setting back to 850 rotations per minute. Here's my Trephine. Oh, that's a nice picture. Okay. And we're just going to use this to clear the bone. Okay, now where did I put the abutment? the abutment. I think I put it over here. There we go. Okay, let's go back and take a look at the implant. You can see what that looks like. That might be a little difficult to see. Okay, and now I'm just going to take this little ring of bone that's there, and now I'm going to go ahead and just lift that out. Suction for me, please. Okay, now let's take a look. Can we have that other camera back? I think it was a better camera view. Can we zoom in on that? No. They're doing that for me. Okay, let's suction. And give us a little more light, please. Okay, take your head out of there. Okay, let's go and put our components on now. Because the component, or the flare, or the lip of the component is wider than this diameter of the implant. Open wide for me, please. Thank you. And so, how do I know if the component's, interfering or not, or the bone is interfering with the seating of the component? If I go ahead and I go to screw down the component and I'm meeting resistance, but it's somewhat elastic and I can tighten it more, I know there's bone in the way. The component should come to a dead stop. If it doesn't come, the screw doesn't come to a dead stop, then I know that there's interfering bone. This looks like it's going to be good now. Okay, our component's in place. Let's take a look. Can we go back to that other camera, please? The one you had before. Oh, there you can see that actually very nicely. Okay, let's take our provisional restoration now. Right, I put it. Okay. Okay, there we go. It's like, where's Waldo sometimes with the instruments and components? They're trying to find them. And now I'll go ahead and I'm just going to slide that into place. Okay, so there it is right in place where we want it to be. Remember what I told you, I don't want to fight with the restoration. I want it to go ahead and just be right in place. Okay, can you very gently close? Wait, open for me, Tidra. Thank you. Can you very gently close for me? Close, 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 close. Okay. And there she is. So it's adjusted to be exactly where I want it to be. Open wide for me now, please, Tidra. Thank you. I'm going to put the throat pack back in. Let's take a look at it from the occlusal view. There you go. Okay, now let's get some, let me have a cotton tip applicator, please, and let's get some acrylic. I'm just rinsing off the provisional. Okay, I take a cotton-tipped applicator. Yeah. Okay, and I just break off a little piece on the end. Let's get some Vaseline. Okay, I'm just going to go ahead and lubricate this so the acrylic doesn't get stuck to it, and I put it right down the chimney of that so that no acrylic runs down there, because if it does, it's going to be difficult for me to remove that. Okay, let's have some shade 62, please. Okay, we have that's in there. Okay, you have a little spatula for me? A lot of people will use composite for this. I still like to use conventional cold cure acrylic. I'm just kind of putting some acrylic. I don't need to put so much into the hole in the provisional restoration. Sometimes I will prime the temporary cylinder and paint some acrylic directly on that. In a case like this, you don't need to put any rubber dam or anything like that on the around the implant, because there are no undercuts here that I'm concerned about engaging. Okay. Now I'm going to take my provisional. I'm just going to slide it right over the cylinder, right into place. Where's my explorer? Do I have one? Okay, there's my explorer. I'm just going to go ahead and begin to clean. Can I get some 2x2s? And a mirror, patient mirror. Thank you. Oh, actually, can I have a college pliers, please? Okay, I'm going to remove now the cotton tip. There we go. I'm going to make sure that there's nothing occluding the hole. Open for me there, please, Teacher. Great. And Teacher, you can close for me. Bite your teeth together. No, keep them together. Good, thank you. Okay, and we're going to let that cure. At the same time, you can begin to see why, I made that incision and didn't trephine through the tissue, because I'm going to be able to go ahead and fill all this tissue out just utilizing this soft tissue here. Just by suturing around this, I filled out the concavity that was there. If I wanted to do more significant fill, then I would reflect further down underneath into the concavity in this area over here under the periosteum, and I put a relatively non-resorbable graft material like a xenograft like BioOS or even HA, something like that, just to support the soft tissue. Now, keep your teeth together there for me. Thank you. Okay, we're gonna let that cure just about another minute. We're gonna take it out, and Dr. Walcock is gonna trim it and polish it. There shouldn't be a whole lot to do at this point. And we'll put the provisional in, put in 2 sutures, and the procedure will be done. Okay, open for me there, please, Deidre. Bite your teeth together. Good. Dip your chin down a little for me, teacher. Thank you. Good. Okay, open wide for me there, teacher. Thank you. Where's that throat pack? Do we have it still? Yeah. Okay, open wide for me, please, teacher. Okay, and here we have our provisional seated and cured into place. Now the final curing can go ahead, Dr. Waltock can go ahead and do on the side. Now let's put that back in there for 1 minute. Okay, just hold that for me, just retract 1 minute. We're going to go ahead and just irrigate that out. I want to make sure there's no acrylic. We'll inspect the area. Suction for me a little more. Okay, leave that camera on, please, for me. Let's see. Oh, you're not going to see that from there. Almost. Okay. Although we do lots of immediate provisionalization, in a case like this where the teacher really hasn't had a tooth there for some period of time, instead of putting the implant at risk, even though she had a high OSTEL or ISQ or penguin value, well, I'm just going to put a healing abutment on. We're going to suture the tissue, and we'll have a provisional prepared for her when it's time to go ahead and load the implant, because otherwise I'm unnecessarily putting that implant at risk. But teacher was a willing patient for us to go ahead and demonstrate this procedure, and that's why we made the provisional for her. So let's get a healing abutment, please. Okay, give me a 3 millimeter healing abutment, please. Okay, now, put it over here. Okay. All the parts and packages, whether it's the healing abutments or the prosthetic parts, come sterilized, which is somewhat unusual for an implant company. Usually, the only thing that comes sterile from implant companies are implants themselves. So we'll look at your packages before you go using them in your patient's mouth. Here they all come sterile. Can we please open that? Okay, here's our concave InDesign healing abutment. I'm going to put it into place. Open wide for me there, please, Tidra. It's nice and snug. And then I'm going to adapt the soft tissue. I'm just going to free it up a little more here so that I can manipulate the soft tissue for a better closure and a little more repair of the concavity that exists for Tidra. Okay, I like to use resorbable sutures, certainly if it's a straightforward procedure. And so we're just going to put 2 quick interrupted sutures into position. Teacher, you're doing great where you're in the home stretch. And I'm going to use that concavity in the healing abutment to my advantage to cinch the healing abutment, the soft tissue, in and around it. Okay, please cut the suture. Not too short. That doesn't work in your left hand. Okay, let's clean that area off and we can inspect it. Suction for me, please. Okay, so you can see we filled out the concavity at least at the area of the pregingival margin, right? And you can see that if we look at it from an occlusal perspective, we've also filled that out without any type of grafting, just by going ahead and not doing it flapless and making an incision that was slightly palatally based. Okay, let's take a periapical radiograph. Dr. Wiltuck, you can go ahead and finish the provisional restoration, and we can finish up. Let's give Tidra a round of applause. Not easy to go ahead and do that. And aseptical for their suction. Okay, let's go back to our PowerPoint. Where's Dr. Brenner? We have a couple more minutes, Dr. Brenner?
Yes, you do.
How much time can you give me?
You got till 5 o'clock, yes?
No, he will be here.
What time? 4:45?
Okay, they want time. 5 minutes, I'm going to get you guys out. 5 minutes. Okay.
He will be here then. Yeah.
Tough crowd.
Okay. So, I'm going to skip a bunch of stuff in the middle over here. And I just want to show you kind of where how far we've come and where we can go with these procedures today. So I'm going to show you this gentleman right here. Anybody saving these teeth? Yeah, I don't think so. This guy hasn't been to the dentist in I don't know how long. You know, I know that you know I have a limited attention span. It's because you know he's in pain and his teeth are all moving and loose. That I even have the opportunity to treat him. And for me to go ahead and adapt a strategy of sequential extraction, provisionalization, extraction, graft, implants, changing over, it's not going to happen with a patient like this. So there's a different approach that we're going to take this patient, but it's the same exact strategy of managing patients, even somewhat complex. Number one, right? We have our CT scan, okay, of this patient. Number two, we have our digital intraoral scan. Goes off to the laboratory. The laboratory does a virtual wax up, a little more extensive, right? This is his entire arch. We're then going to go on to his mandible also, but right now just going to show you his maxilla. CT scan, right? To analyze, right, for position and placement of the implants. This is going to be the plan. The plan is going to go and be to place 6 implants, right, based upon this wax up, a la almost an all-on-4 type of design with angle implants in the posterior and immediate provisionalization. So we're going to extract all of his teeth, put the implants in, modify the bone, place the abutments, and insert the provisional restoration for this patient. This is a very elegant procedure. It's developed by a super innovative guy by the name of Jay Watson. He's actually here today, and produced by Rowe Laboratory. And this is something that you know, can't be done by conventional laboratories. There are other techniques, but none that can do what this one does. So the online meeting it happens. Okay. Oh, here you see the page we entered. I was doing a course with this with Maurice Salama recently. This one I didn't plan with Jason. I planned with Joe. But again, same exact thing. Intraoral scan, CT scan, right? They give me the virtual wax up. I verify that I like it. Implant planning, right? And then I go ahead and do my online planning, saying make these following modifications. I get my box from Rowe. But there's a lot of stuff in my box now, not just the provisional, right, and a small little guide and an implant. You see, all this stuff comes inside that box. I've got models of what the way the patient exists. I've got special positioning guides. See all that metal there? That's actually a surgical guide system and restorative positioning system. I've got pins to pin it in place. I've got models that demonstrate that when I reduce the bone, so the bone's at the appropriate position for the prosthesis design, right, what it should look like. I've got a prosthetic positioning platform. I've got a surgical guide. What do you see what that looks like? I got my implants, I've got my multi-unit abutments, I've got my titanium cylinders, I've got my blockout material, I've got my final curing material, I have my provisional restoration. I've got everything inside there. Here's how it works. First goes something that looks like a surgical guide, that plastic piece. It's really a positioning guide. I make sure that it fits, number one. Number two, once I know that it fits, I can reflect the soft tissue. Okay? I reflect the soft tissue. Now, I attach that metal chrome piece with a pin lock system to that positioning guide. See, it fits together and locks to get together. I seat that in the patient's mouth, drill holes through specific tubes, and then pin the guide, which is really the metal piece, not the plastic piece, to the bone. So I use the teeth. I needed the teeth there because I have a rigid fixed point to fix my surgical guide in position. Now you see the surgical guide and you see this bone, this alveolar bone, right, that's more coronal to the guide itself. Well, I've got to reduce the bone all the way down to the level of where that metal piece is. So I've got to reduce the bone all the way down to this level over here. And I'll initially do it with the rongeurs, and then I'll finish it off with like an acrylic burr. Now the bone's been reduced. I seat a prosthetic positioning platform, and I try in the provisional restoration. See, this fixes the provisional in the exact space for vertical dimension and centric relation position. I'm comfortable and happy that the positioning is correct. I remove it. I seat the surgical guide. The surgical guide now locks into that chrome base with the pin lock system. I use the Paltop guided system. It guides the positioning of all the osteotomies and placement of all the implants. So you can see the implant positions. You can see the implant positions that are here. Okay, you see the implants already inside there. I remove the surgical guide. I insert the multi-units. Here's an angle multi-unit. The report also indicates exactly what multi-units, exactly what positions. If there's an angle multi-unit, how to position it in place. I seat titanium cylinders. I seat the prosthetic positioning platform. I seat the provisional restoration, and just like I showed you there, I put in my wooden stick, I block out the occlusal hole, but instead of acrylic here, I'm going to use this quick up, right, this light-cured composite material, cure it. It's fixed in place. I unscrew it and remove it, and you'll see then I'll come back and in the laboratory, I'll fill the deficiencies and insert inside the patient's mouth, and that's how the patient goes home. So I'm able to go ahead and do a very specific design for the patient. It's the same exact steps that I showed you for that one single tooth, okay? CT scan, surface scanning, right? Merge the data sets, virtual wax up, verify it, surgical plan, verify it, right? And then the tooling is made to go ahead and do all the steps. So if you look at this workflow here and you look at all the steps, there's only really 2 steps as a clinician that you're involved in. And that's number 1, data collection. And then you're doing the surgery. Everything else is kind of behind the scenes. Yes, you'll verify that that's what you want, the design that you want for surgery and restorative treatment planning, but it requires no more appointments. It requires, no more effort on your point. Everything else happens, behind the scenes. So anyhow, we kept you here a couple minutes late. I'm going to let you get out to the booth. But let me just say here, what's that? Yeah, so we're finishing. I know we're finishing. You'll get your codes if you let me finish in the next couple of minutes. Okay? So, Paltop Advanced Dental Solutions, implant systems, libraries that the laboratories needs, prosthetic components, right? Technologically compliant implant system, fully guided surgical system. There's a course for those of you that are interested now in what's that? There's the X-ray of our implant, right? Okay. Right according to our plan. Let's flip back to our slides. Okay. There's a course. You can go over to the Paltop course. You buy X number of implants. I don't know the exact number, and you get a free basic course in implantology and kind of a vacation in Punta Cana. I think it's Dominican Republic. Okay. Rowe Dental Laboratory, located also. They go ahead and they do all the planning. They do all the merging. They create the surgical guides. They go and they from simple to complex and the prosthetic components. And the product called Guided Smile that you just go ahead and see. They're also located 1 aisle over in the Paltop booth. LED imaging, intraoral surface scanning, 3Shape software, 3Shape scanning, right? As well as the Samsung CT machine, right? And Aseptico, that's where you had to use the CaliJet, the implant motor, and the Penguin RFA, the device that measures the implant stability. If you enjoyed the day and you want to learn more, right? So we have a course, 3-hour hands-on course to do simple implant placement, learning, right? Guided surgery, a little more intensive and hands-on for some of the things that you went ahead and saw today. So I'd like to thank you for your time and attention. I'll answer questions, but Dr. Brenner is going to give you your codes.
Let's hear it for Dr. Klein, Dr. Alon, Waltuck. They're a great patient, Deirdre, and a terrific assistant. There should be no reason this was so didactically presented that any one of you, even the assistants, can't do this Monday morning in your office.